So thank you very much, everybody, about all of these lectures were brilliant, fantastic, and I really appreciate the effort that you put together for all of these updates on enterovirus. There are several questions, and I'm going to direct the questions in the next few minutes. But I'd like to start with Rachel. Rachel, your story is very powerful and it's very instructive for all of us who are working with patients. But AFM is not a disease for one individual. It's a disease that affects the whole family. And the book is going to be a great contribution. So I have two questions basically from the audience. Number one is you are taking care of your son. Yourself, are you taking care of your husband, your entire family? And second is the book available in other languages?
Yeah, thank you. Yeah, right now is obviously a crazy time because all of my kids are home and my husband is now going back to work. So we have a pretty tight schedule to make sure everybody is doing something and trying to be somewhat productive with their time and not just on screens all the time. But yeah, I feel like we're surviving all this by kind of leaning into what keeps us mentally healthy. So, you know, through AFM, keeping myself physically healthy has been something that makes me deal with things better. It's therapeutic for me to go running or to write things. So that's kind of how I've kept myself mentally healthy through AFM and now COVID. And the book, right now we have the text written. A few of you have looked over it for me and I'm grateful for that. We're working on getting it illustrated. And hi, Gert, I saw you pop up. Gert, if you want to help me translate into Dutch and German, that would be great. If we can get parents on board who are bilingual and can help get it in different languages, that would be amazing.
No problem.
Great, thank you, Rachel. So there is one question that I like that Janelle help us. And there are many participants in this symposium from Europe. And there is one question, is the surveillance in Europe for enterovirus D68, and what is the collaboration between the CDC and public health systems in Europe that help us to understand the circulation of enteroviruses and AFM? Janelle, you need to unmute.
I'm juggling three screens, so I'm trying to move my mouse where it needs to go. Am I still echoing? No,
keep going. Okay,
yeah. Okay. So it's a great question, and I think we have certainly reached out to our European colleagues for collaboration. We have a pretty close collaboration with Public Health England, and we've been working with our Dutch colleagues, Bert Meesters and his group as well. One issue that we have with surveillance AFM globally is just how surveillance is conducted. So CDC opts in the United States to conduct surveillance, clinical surveillance. So we're looking for acute flaccid weakness. Whereas in other countries, surveillance is done via enterovirus surveillance. And then within those enterovirus surveillance systems, they look for specific cases of AFM. So for example, in Europe, cases of AFM are found through that enterovirus surveillance system and have that have an enterovirus positive associated with them. Whereas you heard in our in my talk, we don't associate a laboratory test result with our case classification. So I think it's something that we need to work more on across the global spectrum. I think certainly finding a case definition that fits more of a global audience rather than just the United States would be very helpful. I know one question came up about what we're seeing in terms of peak years in other countries. And I can say that in terms of publications, we've certainly seen Europe having peak years in 2014 and then again cases in 2016. There was a paper published from Japan that showed a case series in 2015. China recently published a case series from 2018. So again, we're getting bits and pieces of the picture from around the world, but I think one thing that we need to do is to come together as a global community. I think there are some answers buried in this global circulation, right? And when different countries are seeing different peaks in cases. And so that's something that we would like to do moving forward.
Kevin, there's a question that is coming from the audience is, enterovirus produce a lot of upper respiratory symptoms. Many members of the family are affected, and even in families with a lot of kids, only one kid gets hit by AFM. And what is that susceptibility of those patients for developing AFM?
So I think that question is a great question, one that's unanswered, of why one kid is affected whereas others are not. Why we don't see a lot of family clustering, I think, comes down to the numbers. And so I think the majority of us feel that AFM is a very rare complication of a very common infection, and how rare that is may determine your level of clustering. So with poliovirus, for example, it was thought that 1 in every 200 to 500 people infected with poliovirus would get paralytic disease. With enterovirus 71, it's thought to be about 1 in every 1,500 cases. And actually, in our outbreak in Colorado, we did have some clustering with several children from the same daycare getting AFM from EV71. With EVD70, it's even higher, thought to be 1 in every 15,000 cases. And so I think we're thinking EVD68 is probably on the spectrum of a very, very rare complication of a relatively common infection. So it would be pretty unlikely to see that same rare complication in the same family. But as far as the role of genetics and why particular children are affected, we don't have the answers to that. Stay tuned for the presentation from Dr. Priya Degal. She has a really great mindset into not only looking into this for the more recent EVD68 associated cases, but also going back to polio survivors and trying to answer some questions that we've never been able to answer about polio.
Charles, the work that you have done on the genomic analysis, and it's very powerful. There is one concern. It's what we are seeing is a mutated virus, is that there was a introduction of a mutation back in 2012 that is spreading and is perhaps increasing the circulation of a very neuropathogenic virus. So what is your view about that? And the second part of the question is, with all of the genomic analysis that we see, how close are we to get a vaccine being produced to improve or to protect the population from enteroviruses and AFM?
Yeah, those are two excellent questions. So to address the first question, what we discovered in 2015 is that all of the cases of AFM that we identified where we were able to get the viral genome sequence, they all corresponded to one specific group of viruses, what we call a clade of viruses. So one strain was associated with all of the AFM cases, but that strain also happened to be the major circulating strain that year. And one thing I want to emphasize is that it's not as if this particular strain is more neuropathogenic. It may not be. And in fact, it's more likely that it's not more neuropathogenic. We've already been able to show, Ken Tyler's work has already been able to show that other strains of enteroviruses can cause AFM, at least in the mouse model. So what I think it really reflects is that in 2014, what happened was that there was a predominant circulating lineage, a predominant circulating viral strain, and that viral strain happened to be neuropathogenic. But at the same time, very few children who actually get infected. I mean, we see thousands of infections, and the key question is really, why is it that only a small fraction of children actually have the neurological disease? I think that's the key question that we're trying to answer. I can tell you, like, for instance, in our study, we had we had some twins, a set of twins, basically a boy and a girl, the boy did fine, the girl had AFM. And then when we sequenced the virus, we found the viral sequence was identical. They were infected with identical viruses, and yet they had a different response. So I think getting into this issue of looking at the host response and factors, and I think this is why Priya Dugal's work is so critical here, because we really need to answer the question as to why is it that you have a common infection, but you kind of see rare instances of neurological disease. And the other point I want to make is that this is not specific to enterovirus D68. This is true for West Nile virus. But only a small fraction, less than 1% of infected individuals have neurologic symptoms from West Nile virus. It's true for enterovirus A71 as well as many other viruses. So I think addressing kind of this is a critical question that really needs to be addressed. With respect to vaccines, as you can see, vaccine development is extremely challenging, as you can already see by the efforts to develop a vaccine for COVID-19. One of the enteroviruses especially challenging are the fact that one is that they're an RNA virus and they will mutate, they will change over time. So it's very likely that a vaccine may not be durable, and that the protection, if there is protection, may not last. The other problem is that there are over 100 different types of enteroviruses. And so you might postulate, well, maybe we could just target D68, but at least based on sequencing, there's a lot of diversity in D68. And as I said before, we still are unaware of exactly what mutations are needed or what in order for D68 strains to be neuropathogenic. So I think until we can really answer these basic science questions, it's going to be very difficult to develop a vaccine, although I certainly know there's several groups are actually starting to work on one.
Thank you, Charles, for that explanation. Very helpful. Brian and Daniel, some of the data that is coming only from the United States, you show also some graphics from Japan. Is the periodicity of enterovirus circulation similar in different areas of the world? In other words, is coming in the same year, or what is the variation? And it's very important to understand is, you mentioned the latitude effect. So do you mind to expand a little bit? There are many colleagues from South America that are very interested in this topic as well as Australia. Do you mind to expand on this?
Daniel, do you want to tackle that?
Yeah, and at least in the US, we're seeing a latitudinal gradient, which is likely driven by climatic variables. But given the shortness of time series, we weren't able to test the actual correlation with the circulation patterns with climatic variables. But I do also have, so I can't generalize how the latitudinal gradient will affect in other parts of the world, but I also have data for enterovirus D68 in Japan and Hong Kong, and the circulation patterns are quite different. If I remember correctly, in Japan, we see an outbreak in 2013, 15, and 18. And Hong Kong is something that looks just completely different from Japan. So there is a lot of geographical variation, although some studies in Europe also seem to suggest biennial outbreaks.
So I agree with that. So it tends to be, looking in Europe a bit, you tend to be biennial, but they won't be the same. They won't be in phase. They won't necessarily be even years. Sometimes, as we see in US states, a year is skipped. It's this kind of slightly unstable biennial cycle. And then, in the tropics, if we had data, it would be fascinating to see how you then might get something that's a bit more continuous through the year for D68. But as Janelle says, getting all those data together and getting all those groups together is going to be very important for generalizing the very tentative stuff Daniel has done initially on the US.
Just the last question, because we are running out of time, but the models are fascinating, but the situation with COVID-19 is very fluid. So we see that around the country and different states. So your prediction is very important, because for us, we need to be ready actually from now until forever. But can we develop in the next period, like every month or every 2 months, predictions based on what is going on live in different states around the United States? Is that easy to do?
So making the model is possible, but I think the problem is that the enterovirus C68, so we have to be able to adjust the model to the data, but we don't have enough enterovirus C68 data. And the BioFire recently upgraded their version, which also does no longer provides enterovirus C68 data, which is another problem.
Just quickly, in a parallel study, we're looking at another great postdoc in the group, Rachel Baker, has a lovely model for RSV in US states, which captures, it's biennial in Colorado and very shallow annual in Florida and Miami and so on. And we're looking there at what non-pharmaceutical interventions, social distancing will do, and you might get skipping epidemics and all kinds of things. So that'll give us a test of the heterogeneity of the social distancing between states. And then, maybe tentatively we could look at what might happen to D68. But as Daniel says, it would be very tentative because we need more data, really. And that's always going to be a big theme here, I think.
Great. Well, thank you, all of you. Thank you very much for those powerful presentations this afternoon. We need to move now to a stage, and if you take a look on the side of your presentation, if you leave and go to the stage, that will be facilitating the next block of lecture. Thank you very much.
Thank you.